Before we start today's episode, I would like to quickly read you our podcast disclaimer. The content in this podcast is for general reference and educational purposes only. It is not meant to be complete or exhaustive or to be applicable to any specific individual's medical condition. No information provided in this podcast constitutes medical advice and is not an attempt to practice medicine or to provide specific medical advice, diagnosis, or treatment. This podcast does not create a physician-patient relationship and is not a substitute for professional medical advice, diagnosis, or treatment. Please do not rely on this podcast for emergency medical treatment. Remember that everyone is different, so make sure you consult your own healthcare professional before seeking any new treatment and before you alter, suspend, or initiate a new change in your routine. Welcome to The Starting Gate. We're your hosts, Dr. Kitty Dotson
and Dr. Sarah Sheets,
two internal medicine doctors who spent years practicing traditional primary care. Over time, we realized something was missing from modern healthcare. A real understanding of how everyday lifestyle choices impact overall health.
We'll help you cut through the noise of the countless health influencers and their conflicting opinions, because no matter who you follow, the basics of lifestyle medicine are at the heart of it all.
Welcome back to The Starting Gate. We're your hosts, Dr. Kitty Dotson
and Dr. Sarah Sheets.
Hopefully your knees are feeling good after taking all of Dr. Kevin Dennehy's suggestions last week on how to keep your knees healthy. And today we're going to be talking about another musculoskeletal problem that a lot of people have issues with, either chronically or at least something that flares up often for people, which is back pain.
Today, to talk about this specific topic, we wanted to bring a specialist who manages chronic back pain every single day in their practice. So I'd love to introduce our guest, Dr. Shawn Milburn. He works at Commonwealth Pain and Spine here locally in Lexington. Shawn, can you give our listeners a little bit of information about yourself and how you ended up in this occupation?
Sure. Thanks for having me. I grew up in Lexington, trained at UK like the both of you. Initially, I had no idea what my specialty was. I became enamored with anesthesia and actually did an anesthesiology residency when I started and went through the rotations, really enjoyed taking care of patients with all kinds of different problems. My biggest drawback to it when I was in my residency program was not having a longitudinal relationship with my patients. It was kind of like speed dating. You take somebody back for surgery, you have 30 seconds to get to know them and get their trust, and then you don't see them again ever, hopefully. And so that was my big deficiency in my education, my practice, that I felt like I needed a different pathway. And I did a rotation at the pain clinic, which I really enjoyed, and found a nice hybridization between doing some procedures and getting to know patients and make them better, and felt like it was for me.
I know you treat a lot of different pain issues in your clinic. We're going to focus today on back pain because I think if we talked about all of them, we might be here for 5 or 6 hours. But as primary care doctors, seemed like we saw back pain all the time. Do you know how common it is for people to suffer with back pain?
So I think at any point in your life, for all of our listeners, us included, 80% of people are going to experience some kind of chronic low back pain at some point. And a lot of people have acute back pain that resolves. Chronic back pain, 80% at some point. And so if you took a cross-section of everybody in America right now, about a quarter of people have some degree of low back pain that are adults, which is pretty amazing. I was surprised by that number when I was training, but it's really common. And there are all kinds of things that can cause it we can talk about. But I'm always amazed that there are that many people that have it as an issue.
We know from primary care seeing patients, a lot of times we would see individuals when they first got back pain. So what we would establish or call acute back pain because it just happened. And it was always important in those appointments to figure out what bucket do you fall in. Are you in one of those more serious causes that may not be common, or are you in the bucket of the more common causes? What are some of the things that fall in these different buckets? Most commonly, people's back pain is related to straining a muscle or having a disc issue, some type of arthritis, which there are different types of arthritis that can affect the spine, scoliosis, or impacting your nerves and having a nerve compression. But when you come to see a primary care doctor, it is really important to have that evaluation when you first have back pain pop up, because we need to rule out some of the more serious but less common. Typically, less than 10% of all cases are something like a spinal cord compression or an infection like a spinal abscess or a bone infection or a metastatic cancer. Those are the things that you're wanting to rule out immediately. And then when we're talking about those other common causes that I mentioned first, that's when we have to figure out a game plan of how are we going to treat this, because sometimes those will resolve and not become a chronic back pain. But sometimes those are the ones that also end up being a chronic back pain that we need a longer term plan and figure out what we should do for them.
Yeah, or it may have been something where you tend to have this flare up once or twice a year, and then finally it's the time where it flares up and doesn't go away. When you go see your primary care doctor, they're probably going to ask you some questions which you may think seem irrelevant to what you're complaining of, but really what they're trying to do is rule out these things that Sarah was talking about, because those things need a different evaluation than the normal causes of back pain that may turn into a chronic issue.
Yeah, and that's why your doctor may ask you about your bowel and bladder function, how your legs may feel, if you are having any weakness, etc. Those are all really important things when we're trying to distinguish what may be a cause and how we need to work it up. It's also important that sometimes there's other referred pains that can cause back pain, but may be caused by something else that's not related to your back. For instance, a kidney infection or a kidney stone. All these things are hard to tease out, and why seeing your primary care doctor when you have those new forms of back pain pop up, so they can help send the appropriate workup initially.
A lot of times when you go in, you really just want a picture right away. You want to know exactly what's going on with your spine, and teasing out these things with the questions, that's what your doctor's doing to see, do we need to take a picture right away? And if we do, what kind? As the doctor is seeing someone coming in with back pain, sometimes I really wanted to get that detailed picture. But insurance doesn't always cover that. And so your doctor may be teasing out things. Do you have enough symptoms that your insurance is going to pay for an MRI? I feel like everybody wants that right up front. But part of why they don't pay for it at the beginning is because a lot of people do get better over time with some physical therapy and some other conservative measures, which we'll talk about. And so that may be why your doctor may or may not order an MRI at the beginning.
Many times, insurance even requires getting x-rays before you even can approach an MRI. So I know that's frustrating, and I have many patients frustrated with that because they felt it has nothing to do with my bones. Why are we getting an x-ray? But sometimes that's required in order to do that. We wanted to give a little bit of this information because I know many times patients just are confused why so many things and so many questions are being asked up front. And so that's what we're doing initially before we're trying to move on to next forms of treatment.
So in order to just get into more of what do we do for people that have chronic back pain, we are going to introduce you to our friend named Susie.
We wanted to introduce Susie, who has had over about 5 to 6 weeks some back pain that she's been dealing with. She came to see her primary care doctor. She had all the appropriate questions asked. One of those very serious causes of back pain were ruled out. She had x-rays that didn't have anything definitive for the cause of her back pain. And her primary care doctor said, let's do a round of physical therapy, see if we can improve our back pain. And Susie complied. She did her physical therapy, and at her follow-up appointment came in and was like, I'm still dealing with this back pain and maybe slightly better, but I'm not happy with my quality of life and the back pain that I'm experiencing. At this point, this is where we want to have our specialists come in and really explain, how do we walk Susie through this chronic back pain that she is developing at this point, and what options does she have?
The first thing that is important with any patient I meet in the clinic is every patient is different. And so just because Susie's back hurts in a specific way doesn't mean that she's the same as the last patient I saw next door. And big picture-wise, when I meet any patient at all, I tend to differentiate back pain from the low back in 2 categories. There's back pain that will stay in your back and not radiate, meaning my low back hurts, it does not go down my leg. And there's pain called radiculopathy or sciatica, which people will call it often, that's radiating down the leg to the foot. And so I would ask, Susie, is your pain in your back or is it going down your leg to your foot?
Susie today, her pain is located in her low back. She has not experienced any of that shooting pain, and she has had it in the past when she was pregnant, so she knows the difference. But this one is very focal just in her lower back.
Okay, so we would call that axial back pain, which is non-radicular pain. You've already mentioned she's had this come up several times. It's been a few weeks. She's failed physical therapy. An interesting question I ask every patient with this kind of pain is I say, does it get better or worse when you sit down?
Susie's gets better when she sits down.
Okay, and so that's traditional, more of an arthritic type of axial back pain. There are a few things that may not be typical arthritis, like we would think of, like facet arthritis. And we would ask her if she has any heaviness in her legs with walking, or does she lean on a shopping cart when she's at the grocery store?
No issues with that.
Okay. And when we do that, we're screening for spinal stenosis with neurogenic claudication. That is something that would necessitate an MRI typically before we would start a treatment plan. And so once we've ruled out those couple of things, we would go down the pathway of axial back pain. And so in general, when you're at that point with low back pain, we talk about physical therapy did not improve this too much. In terms of injections, which is a lot of what I do in the clinic, we do something called a medial branch block and a rhizotomy for this if they failed all these conservative things. And that typically will give the patient relief for 6 to 12 months for their axial low back pain from facet arthropathy.
And can I stop you here? For someone that is listening that's not familiar with back anatomy, the facet, can you describe and then tell us what is a medial branch block?
The facet joint is, you have one on each side of each level of your back. It's where each vertebrae twists and turns and it stabilizes the spine. So think about it like a knee of the back, basically. And so when you stand for a long time, just like knee arthritis, it can hurt. And so sitting down offloads that facet. Really, in a bigger picture, we call it the posterior column. So your back has an anterior column, which is the disc and the vertebrae, and the posterior column is more like the facet joints. And both can cause back pain. When I asked earlier if your back hurt when you sat down, we differentiate anterior column axial back pain versus posterior or backside column. And so with Susie, it sounds like posterior column axial back pain.
Now, Susie is a little nervous about doing any sort of injection up front and really wants to know what are some other things that she can try to help with her back pain prior to moving towards any procedures or injections.
Absolutely. And every patient doesn't need an injection before we get into all that too. I know it's a lot of times the PCPs who hear us and they're like, oh gosh, I'm going to send them there. They're going to get 20 injections in the pain clinic. I think physical therapy is certainly important. I think trialing things like nonsteroidal anti-inflammatories like ibuprofen. You wouldn't believe how many patients I meet and I say, have you tried Tylenol and ibuprofen? No. You certainly don't need a needle in your back quite yet, then. Let's talk about some of those things.
How often do you see someone improve with ibuprofen or Tylenol and physical therapy?
Often, and especially if they have not tried this before. I see patients who've met 5 different pain management doctors, and I see people who don't go to the doctor at all, who came to a new patient visit with one of you guys and say, my back's hurt for 20 years and I've just dealt with it. Is there someone you know that could help me out? It just depends on the patient. And a lot of this is when I meet a patient up front and we have our initial consultation, I really try to emphasize that pain management is a wonderful specialty that helps out a lot of people. It also comes with some risk. And the risk is we dangle this carrot of, hey, your back hurts. I can give you an injection and it feels better. They come back and they say, my back's a lot better. Now my shoulder hurts too. And before you know it, if you're not careful, they're in your clinic every 3 weeks for an injection. And then they come back to you with diabetes from all the steroids and thin bones and things. And so we have to be mindful and set expectations on the first appointment that, hey, you're 60 years old, your low back hurts. Let's tackle that. If you have acute things going on or chronic things that are keeping you from doing what you want to do, which can't be Olympic level back handsprings, walking the dog, doing the things you like to do in life, certainly let's tackle them. But let's keep an appropriate mindset as well. People's backs hurt. My back hurts. And not everybody that walks in the clinic needs to get an injection. And let's try some of these more conservative things like ibuprofen, like Tylenol, like physical therapy. An ugly topic nobody ever likes to talk about, weight loss.
Yeah, tell me about that. How often do you see that help? Is there a certain amount of weight you need to lose before it tends to help?
It's a summative thing. And what I mean is that if you put forth the effort to exercise and lose weight, you tend to make healthier choices in all aspects of your life as well. And so eating cleaner, exercising, losing weight, I do think it tends to help a lot. And I don't mean for people that have a BMI of 30 necessarily. This is for a lot of the time, maybe 35, 40 BMI. All that extra weight compresses your spine, and getting some of that off and exercising and core strengthening, like your awesome podcast guest the other day, doing physical therapy can really help out a lot with that to offload the spine and help out. So yeah, I think obesity is a huge problem with low back pain.
And with that being said, that is why many times PT is the first stop, because a lot of people do have success with that. And I know many times when you hurt, going to physical therapy seems like the last thing that you want to do. So it is a hard thing to really buy into the idea of doing PT, but many people do have improvement because you're working on that core strengthening, your flexibility, your posture. There's many things that could be contributing to your back pain that a physical therapist can help with a lot.
Yeah. And it can be frustrating when you think as well, okay, I'm struggling with this back pain. I can't move the way I want to. And you're telling me to lose weight, but that will still help you. So thinking about what you can do that's not unbearable for you, and thinking about maybe what you can do with your nutrition to help bring your weight down, or even talking to your doctor about other options like medications to help with that. If that seems like that's something that's really causing more compression on your spine and more pain, then it's worth going down that road a little bit deeper.
Yeah, and I think physical therapy is a great thing to talk about, because another thing I see all the time, I've done physical therapy in the past, it didn't help. And as you all know, just like a pain management doctor or a knee surgeon, every physical therapy office is different. And so I'll often ask my patient, if they say, hey, physical therapy didn't work for me, I'll say, what did you do last time? Let's say my neck hurts. And they say, I got in a bike and rode on a bike for an hour at PT for 3 weeks. And I'm like, did you get dry needling? Did they decompress you? What did they do? And I think that physical therapy gets viewed in this blanket of it didn't work sometimes. And sometimes it's just getting them in with the right physical therapist in the right office and making sure they actually do good physical therapy. They're not all the same.
That is a good point. And you want to be sure, just like with your doctors, you have a good relationship with your physical therapist and know that they're doing all the things to help you out. But in this bucket, we still know that there are going to be patients that don't improve with physical therapy when it comes to this. And we know Susie had a great physical therapist. She did all the things and got a little bit of improvement, but still was having some of that substantial pain. And one of her questions that she's interested in, are there any sort of heat or cold therapies that she should be using at home on a regular basis that could help?
Sure.
Is that a bucket that she maybe hasn't tapped into?
Certainly. For axial back pain, it's never as simple as just a bone or just a muscle. Often when you have this chronic low back pain, your muscles are tight down there. You can use a TENS unit, which you can buy on Amazon. They're not expensive. HSA pays for them. You can use ice. You can use heat. You can use an inversion table at home to decompress your spine. If you're able to get on one, don't flip out of it. You might have to come see me sooner than you want to.
Use those with caution.
Yeah. Ice, heat, a TENS unit is a wonderful tool for myofascial or muscular pain that can happen as well in the low back.
Outside of those specific things that we mentioned, is there any other bucket that maybe Susie can try before going next step with any sort of procedure?
And I'd have to talk to Susie for a little bit to tease this
Okay.
out. A lot of the time, pain is not always an organic, like nociceptive, or I have an arthritic problem. When you live with this, and she hasn't had this for a long time, but we're in Kentucky, a lot of patients have had back pain for 20 years. And they've changed their life. They're not able to do the things they wanted to do. It's not just a physical problem. It becomes a psychological problem too. On each visit, I'll try to pick a little bit into that and see where they are in terms of just mental wellness with how are you doing with, nobody ever asks that question. Like, how's your back? It's not great. But how are you dealing with your back? How well are you? And people will become emotional in the office just because you think about it. If you want to go play with your grandkids and go to their baseball game and you've got to sit in the car and watch it because your back hurts, that's a really taxing psychological toll on people. And it's never as simple as an arthritic joint or a herniated disc. And sometimes people have a story, and even just listening, and you can triage them to a person that can talk with that about them too. It's not just an organic problem like that.
Yeah, I know I saw that a lot in clinic where it really does affect your whole quality of life. You may not be able to work like you wanted to work before, or you may not be able to go on trips with the rest of your family because you know you're not going to be able to walk or do everything that they're doing. And so for someone that has dealt with chronic pain for a really long time and really being let down about aspects of their life from dealing with this or thinking about pain all the time, how do they find someone to help with that psychological component?
There are actually pain psychologists that do this all the time. And so the most common way that we use them in our clinic is they serve as a screening tool for some of the more invasive procedures we do. They do an evaluation for us, but they also offer CBT and counseling. And we have an intake questionnaire on those tablets everybody loves to fill out at the doctor, right? There are 40,000 buttons to click. There are some red flags on our intake tablet that can say, hey, this person might benefit with having a psychological consultation with a pain psychologist. There are lots of ways to do it. I tend to find that active interaction with the person is a little better than the questionnaire. But really, a pain psychologist can be really helpful with not just, a patient asked me this today, actually, like, why do I need to see a psychologist? I'm not depressed. It doesn't mean they're going to give you a magic wand to make your back feel better, but sometimes even just verbalizing what you've lost, doing some strategies for coping and working around it, and actually having someone that listens can be a really helpful therapeutic tool And it's a great thing to do.
I think that's a huge bucket that's missed. And the chronic pain management is really, just like you said, we're not addressing the fact that an individual has lost a part of their life. Because that's what usually pain takes away, something that you were once able to do, and now you have so much pain and you're unable to do that. And so using tools of someone who is trained in addressing pain in this way and undergoing cognitive behavioral therapy can be very helpful in just learning how to manage this new normal that sometimes people have reached. And it is different than what it is before.
Shawn, do you know if someone was looking for that, is there something specific they should search, or do you know if there's a database for pain-specific therapists?
Like a pain psychologist?
Yeah.
So there's a pain psychologist at UK who worked in the office with us who is wonderful, who does a lot of this and sees consultations on her own. Her name's Stephanie Judge. There are a couple of different facilities in town that have this as well. Dr. Jonathan Cole's another one. You are typically referred to them by your physician when you talk about it, but certainly they will do CBT even without any kind of an injection therapy or a pain management consultation. I got a referral the other day from one of them for a patient who'd been through CBT and had gotten over some of the psychological aspects of their pain, and they were ready to tackle it with more of an interventional approach at that point. I think they can be really helpful, but every patient's different. Herniated disc, I don't think you need to go to CBT. You need an epidural, but certainly when you find things are out of proportion in terms of, I don't want to say catastrophizing, I don't want to gaslight a patient. Hey, I can't do anything, I'm on the couch all day. Those patients are really good candidates for some CBT and just having somebody listen, because we're stuck as doctors with this very finite time slot for clinic, and where it's sometimes hard to get into the weeds of how are you doing? And when you need to, you screen for severe problems, but we probably underserve that quite a bit, especially in pain management when we're in a hurry. And so I think that's a wonderful person who has lots of time to sit and pick through the different psychological aspects of your pain in your life and what's there and what's not. And like you said, you're losing a part of your life. It's like almost like grieving. It's a big adjustment. And so I think it goes really well with especially chronic back pain. And we're really more into the chronic pain side of things more than acute pain.
And another aspect that some people find helpful in learning to deal with more chronic pain is the practices of mindfulness or meditation. Is that something that you see any improvement in patients with their pain perception?
It's not a lot different than physical therapy, to be honest, for me. And what I mean by that is that it works great with patient buy-in. And you all know the patients come in and they say, I've already done PT, I don't want to do it again. I'll go to one session. And I try actually not to send them because I don't think they're going to do better. And with mindfulness meditation and things like that, I think that if patients are looking for something like that and you talk to them and you screen them and they say, hey, I'm upset, I will typically pair that with the pain psychologist and have them plug that, instruct them on how to do it. And each patient's a little different. But yes, I think it's a great tool, especially if you don't want to go get cognitive behavioral therapy each day. It's something you can do on your own and kind of sit and reflect and kind of dial things back in with pain and resetting the baseline. Yeah.
Okay, so we have Susie here. And as we mentioned before, she'd seen her primary care, had a really great physical therapist. She's not at the point where she needs a pain psychologist, but she's tried some of these other methods that we had talked about. Now she's ready to explore options with you as her pain specialist. What things would she even be offered?
And I wandered into this a little bit earlier. With her pain not going down her leg, I wouldn't necessarily order an MRI right away. And like you all talked about earlier, a lot of patients walk in, they're like, I want the MRI. And so there are lots of clinical indicators for one. And at this point, she would not get one with her story. I would probably start with an arthritic-based treatment plan for her with interventions. Typically with this kind of back pain, you would come in the office and lovely insurance requires you to get 2 diagnostic injections where I numb up these joints in your low back. And so you get lidocaine and bupivacaine, which would last between 20 minutes and then 4 to 6 hours. I would numb the joints up. She would get off the procedure table after the x-ray, and she would walk around and see if her back feels better. If it feels better temporarily, we would bring her back in 2 weeks because of insurance requirements, do the same thing once more. And then at the 4-week mark after the first injection, she would come in for something called a rhizotomy or an ablation. And at that point, she would be sedated with an IV for patient comfort. We would numb up the same areas of her spine and those facet joints with numbing medicine. And it's really neat. We would take a little wire inside the needle and ablate or cauterize that little piece of the nerve that causes the back pain and makes you feel that joint. and it would go away for 6 to 12 months if we're correct with these diagnostic shots, which we usually are pretty good about. If 2 of those work, this will work. And that should take care of this axial back pain we're talking about for her for at least 6 months. And you can do it up to twice a year with insurance.
And then do you see people where one time is enough and they don't tend to have problems for maybe years down the road, or do people usually come back in 6 to 12 months?
And it really depends. If you have a patient who walks in that says, hey, I'm really active, I play golf all the time, I'm swinging 120 miles an hour with the driver, I'm probably going to see you when golf season starts up. In general, with this kind of pain, it's typically a chronic pain picture. And so we usually see them once or twice a year. I have patients sometimes who love it. They come back. I had a lady from my first year out of practice, came back about 3 years later. That was like, that was the best thing you've ever done for me. I'm ready to do it again. And I was like, I'm so sorry. You have to do the repeat test shots because insurance has this 2-year clock of resetting everything. Most people get between 6 and 12 months. You all know this just as well as I do. If any doctor ever tells you something works for everybody, you should run. Because the reality is medicine is not perfect. And I'll usually counsel my patients when they come in as well for these procedures that, hey, this works for most people, and I would expect some good relief for 6 to 12 months. If it doesn't work, you don't have to do it again. But it doesn't work for everybody. Some people come back and say, hey, it lasted for 6 weeks and my pain's back. And those ones, typically at that point, Susie would get an MRI of her low back to look for less common causes of back pain.
And for people that it did help, let's say for that 6 to 12 months, does it take all of their pain away?
And that's a good question because pain is not simple, right? So my back hurts when I stand and walk. Okay, I can stand and walk now without pain. My leg's bothering me now that my back feels better. Why isn't that better? And we're like, you didn't really have leg pain at the first evaluation. And then the most important question you ask at a follow-up like that, which I think everybody doesn't do, is you say, Susie, would you be here with this leg pain if it was the only thing going on from the very beginning? And a lot of people will say, no, it's just now I notice it. And you're like, okay, let's let it be and do more PT. And let's remember, each of these things can exist and they're there, but not all of them need to be injected.
Yeah.
If it's there and you notice it and you can do everything you want to do, that's your body telling you to take it a little bit more easy or lose weight. There are lots of ways to attack these things without poking a needle and everything all the time. But if she does it and then her leg hurts and she's not able to go walk and do things, then we would get an MRI and look at other causes of that kind of pain. But usually if something gets better like that, people will notice other little knickknacks that are bothering them a bit.
So if she gets a lot of relief, let's say Susie is 60 and is otherwise healthy, she's got a long life to live ahead of her. Does she do this every 6 to 12 months for the next 30 years?
That's a great and smart question I don't get asked all the time. There's a bigger bucket of things where you're like, patients, hold on, I might have to get this every 3 months for the next 30 years. And it's a loaded question. You can. An ablation or a rhizotomy we're talking about is probably a bit different than like an epidural because often from a surgical standpoint for a neurosurgeon or an orthopedic spine surgeon, this axial back pain stuff is like run. They don't want to operate on just back pain. And so I'm left a little bit more to my own devices and making people feel better. We would certainly use NSAIDs. You try to space it out as much as you can. The other part that's hard is patients will come in and they'll be like, hey, I got that ablation 6 months ago. My back hurts again, but it's not as bad as it was. Should I do it again right now? And the answer is no. See how long you can go until you're not able to do the things you want to do. That may be 9 months, that may be 15 months. I try not to live on this insurance-based schedule because the ugly side of medicine is we have all these thresholds of where people have to get better for X amount of time. And then we call and we're like, hey, you're up for an ablation again. Do you want another one? And they're like, I don't know, my back doesn't really hurt. Maybe I should do another right now. And no, do not do that. And so let some of the pain come back slowly. Modify your lifestyle with physical therapy, eating better, losing weight. And when you hit the point again where you're like, hey, I'm not where I want to be, I can't do what I want to do, I would be back in this chair for this consultation again right now, then that's when you go back and do it again. That's what I tell patients when I see them for follow-up.
And you brought up a great point, and I think it's very beneficial that sometimes after having an injection, you've managed your pain to a point where maybe doing additional PT, you'll get more out of it. And so sometimes that is helpful. So you are being more proactive and maybe doing some more work with the muscles around that area as well that you couldn't do because you had such substantial pain before. as well as when you have less pain, it makes it easier to do some of these other lifestyle changes of changing your nutrition, working on sleep. That's also something that when you have your pain better controlled, that you can get better sleep quality, that maybe overall your pain can be better managed long term with other lifestyle aspects, but not always talked about as using that in the in-between periods as well.
Physical therapy is not for just the beginning of a treatment plan. If it helped in the past and you weren't where you wanted to be for the injection, like you said, go back afterward when you're feeling better. You can do more things and strengthen. Totally agree.
So let's say we have Tom, who is a young 42, and he lifted something that he shouldn't. I would never do that, but he lifted something that he shouldn't. He suddenly has back pain, and it is shooting down his left leg. He can still walk, but he's definitely walking funny, and he comes in and needs help right away. He says, I cannot do my normal life. I can't take care of my kids, go to work, and do all this stuff like this.
What we call that in the pain clinic is called a hot disc. And so when you have somebody with acute new onset low back and leg pain, this is one of the most uncomfortable things you can ever have in your life. You can't find a position that feels good. It's almost like how a kidney stone would feel. You're moving, your leg hurts like crazy. You can't sleep. It's this awful snowball of catastrophic pain. And so these people will come in and they'll be in pajama pants and they won't have any sleep. And it's awful. And you'll have seen this as PCPs, and they show up and you're like, hold on, I know, Sarah, I know you.
No, they come in a wheelchair.
Yeah.
I saw it.
And you're like, you go to the ER, what's going to do with this? And so, when you have this acute pain like this and you're not weak and you've just got raging pain, this is a little different than Susie. So Susie had chronic back pain that didn't radiate. And so these people usually, someone like you guys will call me on my cell phone and say, hey, I need a favor. I need you to see. Tom's a nice guy. Tom's got what sounds like radiculopathy. And so I'll run late like I was today for the podcast and add him onto the schedule at the end of the day. And Tom will wheel in his wheelchair, looking disheveled and being miserable. And Tom needs an MRI. And like ASAP MRI, call the MRI center and say, hey, I need a favor. Let's get Tom an MRI today. And what we're looking for on there is nerve root impingement. So this kind of back pain is completely different than pain that stays in your low back. When you have pain shooting down to your foot, you likely have some kind of a pinched or irritated nerve. And with his acute setting here from lifting something, he probably herniated or has a pretty impinged nerve root disc or instability. And MRI will show us exactly what that is with soft tissue. It's a little different than an X-ray like you all talked about earlier, which shows us bones. And on an X-ray, we may see disc height loss. Like you might see L5S1 looks a lot smaller than L45. But really an MRI will show us soft tissue there. And Tom will hustle off to get an MRI. We may give him a steroid dose pack, which you all are pretty good about doing already, unless they're diabetic. We don't do that for diabetic people. Some medications in this case can be really helpful, like gabapentinoids. Gabapentin or Lyrica are really nice medicines for radicular pain. And so Tom will get his ASAP MRI, and he'll probably come by the clinic and drop it off that night because he's stressed about his back and leg hurting. And we'll call him in the morning.
And it may be a couple of days, Tom, just so you know.
Oh, yeah, sorry. Yeah, not everybody does that. You're right, Tom. Sorry, Tom. And we'll likely see a pinched nerve. And so in this case, you said Tom was not weak, right?
Correct.
So he doesn't have drop foot. He's not dragging his foot around. He's not having bedwetting accidents on himself. No incontinence.
Again, those red flags we mentioned earlier. When the doctor keeps asking you, how are those bowels moving? How are you peeing?
And with Tom's disc herniation, in that case, this is a different patient than the chronic low back pain patient. I would not send Tom to PT yet. So Tom would come back in, and we would look at his MRI, have him on Lyrica and gabapentin, and his steroids hopefully feeling a little better, and Tom would get an epidural steroid injection. At that point, and we're in the week to 2 week phase at this point after the MRI and the injection, if he's starting to feel a little better with the steroids and the injection, then Tom would get PT. And another thing we didn't really talk about back and acute leg pain and back pain is sometimes the best healer of all is time. Your body is built for these things to happen. And as ugly as an answer is for a patient in pain, sometimes you just got to grind it out and let your body clear out some of that inflammation and feel better. And now this is at a time when you can't do that. If you're a doctor and you have a full clinic schedule, that's hard to rest and do that. But rest in time is sometimes not a bad thing either, because whisking Tom off for an epidural and then ASAP surgery might make him feel better in the short term, but that comes with a lot of awful things that can happen down the road too, with degeneration and complications. Try the MRI, try the epidural, try some Lyrica or gabapentin and some steroid. Let your body heal some and rest and let that disc clear up.
And I think the big thing to understand about when you have that acute disc herniation is you have such a huge inflammation response. And so that's what the time really needs to kick in for that to heal up and to feel better. And I want to flip this. So we talked about this MRI showing that, but many times when patients get an MRI, it'll talk about disc herniations, but they don't present with these acute symptoms. So can you also have this chronically over a slower period of time, or how do patients look different in that scenario?
Sure. I love the patients that come in who are really sweet and they're going, no, I got the degeneration.
Yeah. How many times have I been asked, what is this, a degenerative disc disease? Are they falling apart?
It's a confusing term.
It's a confusing term.
Like, it's over. I've got degeneration. Nothing can be done. I think that the biggest thing with this is you use an MRI as a correlative tool for a treatment plan. And what I mean by that is that when I meet you and I talk with you, the most important thing I do in my clinic is my history and physical exam. And so if you come in and you say, my left leg is on fire, and your MRI says you have a disc bulge on the right, I'm not going to do a right-sided epidural. I'm going to treat the patient. And that doesn't mean that the MRI isn't helpful, but I think it's a confirmatory tool for a good history and physical exam. And so if we MRI'd all three of our backs, we probably all have some degeneration and maybe disc bulges. And an MRI is a great tool to correlate with that, but none of us are sitting here moving around like we have a disc herniation. In general, I view it as a confirmatory tool, and I treat the patient, not the MRI.
And for people that are scared about getting an epidural injection, can you talk for just a minute about what does that entail? Do you have imaging that's showing you where your needle is going? Are you potentially going to paralyze a patient? Are they awake the whole time? A lot of people are really scared about that whole thing.
My favorite one is, hold on, I got one of those when I was pregnant. And
you actually gave me mine. Do you remember that?
I don't know what you're talking about. I don't know. I remember when I did it, you looked at me like, man, remember us back in college being friends and then we're giving me an epidural right now? It was all you could do not to cry. It worked okay.
It worked. It was excellent.
I don't do that kind of epidural anymore. So people often think that these epidurals are like labor epidurals. And when we do those, if you haven't had a child before, you bend over the basketball in your stomach and you try to hunch your back out between contractions, and we poke and prod around and feel our way into your epidural space, and then blindly thread a catheter up there to numb your legs and your back up so you can have a baby. That's not what we do on this one. So when you come in the clinic for an epidural, now for me, I have to use an x-ray machine because I'm probably not as skilled with tactile epidural placement as I was back in the day. But you lay on a table on your stomach. We use a big x-ray machine around you to take x-ray pictures of your back so we can see the different bones and where they are and where we need to put the needle. Based upon your MRI and your symptoms of where you hurt, we put a very small needle after numbing you up into that space where the problem is. And then we put some steroid medicine, typically a little bit of contrast, and sometimes, depending on the type of epidural, some numbing medicine deep in there. So for Tom earlier with his acute radiculopathy, Tom would be getting 2% lidocaine with his epidural to make his leg feel better in the short term when the medicine goes in. But the real work is by the steroid medication that goes in there. It will help decrease the inflammation and knock down some of that pain. Now, Tom won't feel better if he herniates more disc because he feels better 2 days later and goes and lifts another couch. But it's a great tool to decrease that inflammation, especially acutely, and get people on the path to recovering and letting their body heal itself from that herniation.
And is Tom able to drive himself home after that? Does he have to have somebody take him home? Can he go to work later that day?
All great questions. So if Tom gets sedated, he cannot do any of this. I had to tell people that before. And epidurals, there are different types. So there is a version of it where we numb the leg up quite a bit for a low back epidural. And so you have a heavy leg for a few hours with the numbing medicine. So you can't drive then. But we can also just do it with normal saline or just water, basically. And then the leg will work fine. They can drive. But most people can drive afterward unless they're like Tom and miserable, and they need to be numbed up really well.
Now, in that situation, do you typically have to do something again for Tom, or is that one of those injections that may be a one and done?
People with acute radiculopathy or acute pain going down their leg, typically within about the first 4 weeks will show whether they're going to end up on the better treatment path or they're going to need something more complicated. And so I'll typically see you for a consult, get your epidural done within a few days if you're in that situation, and bring you back within 7 to 10 days and just see where things are. And if you come back, you say, hey, Doc, I got better for a day and a half, and it came right back. Then at that point, we're already shifting our conversation to say, okay, we can do one more epidural and a different approach. And if this doesn't work, we probably need to get you in with a surgical specialist because this is not getting better. If you come back in and you say, hey, it's much better than it was before. It's coming back some, but I'm able to do what I want to do. PT, work this out, come back for one more injection if you need to get over the hump. Those people tend to get better. It doesn't mean it's not going to flare up again at some point, but that's the big split for patients, I think, is a 2-week mark after the incident when you've had an epidural. Are you on the progress of getting better or worse? They will tell you which way they need to go.
Let's take Tom back in time and say that he did have this horrible pain acutely, but he also noticed that his leg was extremely weak. It wasn't, he couldn't stand on it because it hurt, but he couldn't even move to stand up. What about that bucket? Is that someone that you end up seeing, or is that when we're sending them to a surgeon?
So I think it depends on the surgeon, number one. And number two, it depends on, is Tom healthy? Does Tom have 5 areas of stenosis, or is it a simple 1-level disc herniation? I don't know that, like all medicine, there's not a right or a perfectly wrong answer. I think if he's weak, you probably would want him to see a spine surgeon sooner than later. Now, that sometimes can come from someone like me who can call somebody and get him in quickly. And so sometimes it's not a bad thought to just send him to me and say, hey, I need him to be seen not in 3 weeks, like today. And then I can do the same thing again with a neurosurgeon or an orthopedic spine surgeon. And for those people, I usually call the surgeon and have them look at the MRI remotely before they see Tom and say, hey, do you want an epidural or do you want to just see him for surgery? If you're weak, you do not want to delay MRI evaluation by some kind of a spine specialist who can get you in somewhere. People often think, though, with acute pain, they need to go straight to the surgeon, though. And a lot of the time, they will get sent right back to me for an injection unless they're weak. But the weakness part and the incontinence part like that, certainly earlier than later, they should see a spine surgeon. Definitely.
And all these things is why it's important. And message we want on this show is you should be seeing a doctor immediately if these pop up. This isn't something you're waiting at home and I'm having weakness, or I'm noting I'm having bowel or bladder dysfunction and trying to just bear it and see how you do in 48 hours. You need to be evaluated by a doctor ASAP. Those are just different, and we just want to be sure that we get that message across.
Yeah.
So let's have another person. Let's have Joe.
Tim's dad.
Joe is Tim's dad, and Joe has done a lot of physical labor throughout his entire life. And he is now retired, and he has had chronic back pain for a long period of time. And he has also had radicular pain that he's dealt with for a long period of time. But he's just reached that point that he's just tired of it. And he saw his primary care doctor, went through everything, and ended up in your office. So he's similar to his son, but it wasn't an acute onset. Do you treat those differently? Are there other procedures that you use, or can you still use an epidural?
I think I'm much more likely to get Joe. The name's Susie,
Now we're to
Joe,
Joe.
Tom. Yeah.
We've had Joe, Tom, and Susie. Yeah.
Tom, yeah. So Joe is a bit different than Tom. Joe's had this for a long time, and he's finally checking the box of getting somebody to do something about it. I think Joe would be much more likely to get some x-rays of his low back and be sent to physical therapy. And he would probably fight me about that because he's worked hard his whole life. I've done therapy. I lift bales of hay that are heavier than you. I've done all that stuff. And Joe would be a drag him to physical therapy person and at least give it a good chance. Joe would need to go to a good physical therapist too. Because if you park Joe on a bike for an hour, Joe's going to leave after 15 minutes and just not come back.
Yeah.
And so Joe would start there. One thing you didn't bring up, Joe often shows up to my office on opioids as well, because they've had this for a long time and never really sought treatment from a back specialist. And opioids are an ugly word to talk about. And that can make things a lot harder with what I do, with what spine surgeons do, not because they're not effective tools for some patients, but because they can make the recovery process of this a lot more difficult with treating pain.
Why is that?
Sure. So opioids in general, for you guys who don't know, we're talking about Lortab or Percocet or oxycodone or tramadol. Any of these things are classified as opioid medications. They are wonderful tools for patients who have acute surgical pain. So if you go and get your gallbladder taken out, it doesn't feel good afterward. Opioids are designed for that. And back in the heyday of opioids, you could get them from any doctor anywhere. There was a grab bag to go of goodie bags of OxyContin you could take. More recently, we've had a lot of pushback in the healthcare litigation industry, reform of prescribing methods and things. to where it's probably all the way to the other end of the spectrum,
Yeah,
to where
we've
like
gone too
nobody
far.
can ever
Yeah.
have opioids ever in their life. But the reality of the way they work is really interesting. So they, in your body, they don't selectively act where your pain's coming from. So if you've got a disc herniation, they don't all shoot down to your spine to treat. They indiscriminately go everywhere, and they bind all of these receptors that cause pain and block them. And so they're awesome for acute pain or surgical pain that's not supposed to be there. The trouble is when you take them for a long time, you develop something called tolerance. And so people in the world of non-pain management often equate tolerance with dependence with addiction. And actually, there are really 3 totally separate categories of substance use. And so tolerance, what I mean by that is if you say Joe started off and his doctor gave him tramadol and he was taking it once a day, it did great all day. 3 months later, Joe comes back and he says, hey, Dr. Sheets, I'm not really getting as much better with the tramadol as I was. You think I could have 2 a day? And being the good-natured, wanting to help doctors you guys are, sure, Joe, try it out. There's this feedback loop that happens to where they work less effectively and for less time. And it's not because Joe's an addict at all. And we'll go over those definitions in a minute. But the reality is your body is plastic. And what I mean by that is it can change its physiology based upon whatever situation it's in. So if you give your body opioids every day, you will make more opioid receptors, just like beta blockers work the same way for y'all with hypertension. The way they work is they work so well that we become tolerant. And then when we become tolerant, we often chase this carrot again of this increased dose or frequency. And the ugly part of medicine is that patients don't do anything wrong to get in this situation, but they hit whatever the arbitrary threshold is for you. And yours might be different than yours and might be different than mine. But hey, you know what, Joe? You're on hydrocodone 10 3 times a day. That's the most we write in this clinic. Sorry. Joe's body doesn't hear you say that and stop being tolerant. It keeps doing what it's doing. And you might pass him off to a pain specialist and say, hey, Joe's Norco isn't working anymore. Godspeed. And the hard part is that's not Joe's fault. It's not your fault either. But the challenge is finding ways to avoid tolerance, because the next step after tolerance is dependency. And what I mean by that is when Joe doesn't take his hydrocodone, he notices and he feels anxious or irritable and can't sleep.
Yeah, it's not just the pain, it's other symptoms.
It's this decreased dose of opioid. And so the last step of it is addiction, which is completely different, where Joe is breaking the law to obtain the medication, which most people don't get to. But it's a slippery slope. And with opioids, when you take them for a long time, most people become dependent at least. And that's hard. And they're hard patients to treat, not because they're not nice, not because they don't have real pain, but because when you hurt all the time everywhere, there's not a great reality. Everyone has a threshold. And the other hard part too is you might ask, why don't you just give them more medicine? You could. The side effect profile of opioids, which is dangerous in its own right as well, with constipation, with hormonal changes, it messes with your testosterone and your estrogen, your sleep-wake cycle. You don't become tolerant to that part. There are people that could take an oxycodone 10 milligram and not feel any pain relief, but they will still get stopped up and be constipated. That's why opioids are hard. And that's the whole genesis of the opioid epidemic, is that small thing there. And so we still fight that battle. There are some people that do what I do who never write any opioids at all for patients. And then if you're selective about it and people have failed everything, or they have cancer-related pain, or they have post-operative pain, being selective about how you use them and really being a good steward and not being irresponsible with it is probably the best way to do it. The best part for you all, for pain doctors, is you send somebody somewhere and you're like, hey, I inherited this patient from another doctor. If I did not start this, please help me. And we're like, I'm only doing injections. And you get them back and they're like, I don't like that doctor. It's
oh my
hard,
gosh, this has totally happened.
It does. And we're like, why did you send them? And it's where communication's really effective. And so if Sarah called me and said, hey, I got a bit of a tough patient I need your help with, it's a lot different for us too. Communication, even with doctors, is super important with that. Every doctor is a little bit different, and try to treat the whole patient and be empathetic.
And we do want anyone listening to understand you are in such a predicament when you are this patient, and your doctors are in a predicament, and everyone wants the best for you. And it can be so hard. And I can only imagine how frustrating that is for people going through this.
That's the other part too, is if you get dependent on these and you're a compliant patient, you take them the way you're supposed to, you've never done anything illegal or wrong, and you get sick and you have to move back home from Florida to Kentucky, and you show up and you're on your regular pain medicine, you've got to find a place for somebody to do this for you, and nobody really wants to do it. That's the other ugly part of opioids, is you've got to find somebody to help. And often, unfortunately, it falls upon primary care doctors to do that. And then you've got to twist the arm of some pain doctor to help you out sometimes. But it's hard. It's hard for patients. It's hard for doctors. And ultimately, it's not when we say things like, hey, we want you to decrease your medication or try some other things. It's not because we want to be mean or bully you or manipulate you at all. It's because we see this. Every patient who goes through this is not that different with this longitudinal timeline. And we know where the train stops. And I personally, at least, do not ever tell a patient, sorry, this is what you get. Deal with it. Deal with it's like the worst thing to tell any patient ever. And so I try to stop the train before it leaves the station is what I try to do. But every patient's different. You got to be selective and treat them differently. There's a new NSAID that just came out called Tolectin that we use a lot. It's a newer, quicker onset NSAID that we've been seeing some pretty good results with versus standard ibuprofen, Celebrex. It's not too expensive. It's reasonably priced, and I've seen some encouraging things. Just here's the other part we didn't talk about. Just like opioids, we act like these non-opioid medications are always benign as well. You guys, I'm sure, had patients that eat ibuprofen all day, every day, or eat 5 grams of Tylenol and show up with a liver failure. The reality is that there's no truly benign medication to take. NSAIDs, if you eat them all day because your back hurts, you don't want to come see me, please don't take so many that your kidneys don't work anymore or your stomach hurts. And people forget that these easy medications that are over the counter can hurt you as well.
So for Joe specifically, if he has had this chronically, and maybe he was more of the route that he just ate a bunch of NSAIDs, and he's coming to you because his primary care doctor is, you got an ulcer, Joe. We got to do something different. Will injections help him in that situation?
I think they can, but I think Joe's a great patient to talk about expectations about, because Joe has lived for many years with this. And if Joe comes in and he's never seen a spine doctor especially, and he meets me and I get him all excited about this injection, everything's going to be perfectly back to normal. You don't need pain medicine anymore. You don't need your NSAIDs. Joe's going to come back even if I make him better and not be happy. And so he is a perfect other example. You said he has back and leg pain. So one thing I really try to teach my nurse practitioners and PAs and younger doctors in our group is when you talk to somebody in the clinic and they have low back pain, you have got to ask, is it in your low back and your leg or just your back? And patients, about 90% of the time, like Joe, will say, I have pain that goes down my leg, which ding, MRI, epidural, that's the way that insurance wants you to treat them. But then if you ask Joe, he'll say, really, I'm here because my low back hurts. And like my leg's very occasional. You may have to order an epidural steroid injection for him first to satisfy the insurance almighty overriding gods. But when you do that, you have to explain to Joe and say, Joe, this is for your leg. This injection is going to go in your back. There is a very real and almost likely scenario that your back will still hurt afterward, but your leg will feel better. And if you tell that to Joe and he says, I don't want the injection, my leg doesn't hurt, then you got to find a different plan and say, let's go back then. Does your leg even hurt at all? And revise your note. But I find a lot of disappointed patients with injections weren't told beforehand what to expect, how long to expect relief, and what should actually feel better. I think if you weren't medical and you got a shot in your back, you'd think your back was going to feel better.
Oh, definitely. Yeah.
Right? And in the world, except for some circumstances, really for back pain. It's for leg pain. And so when I do that and patients come back in, the best version of a patient with low back pain comes back and says, hey, how was your injection? It was great. I'm doing awesome. My leg is all the way back. My back still hurts. Can we do the other thing you talked about? And then when they come back for their follow-ups in 6 months, 12 months, or whatever happens, they'll come back in and they'll see my PA and they'll say, hey, Lindsay, my leg's hurting again. I want that epidural. And those patients who take ownership of their care and are educated and understand what we're doing and why we're doing it do great. They're the best chronic low back pain patients. And really, the burden of that is not my PA's job. It's my job. At the first visit, you need to take time and explain what you're doing and why you're doing it so that the patient will buy in and understand what you're doing.
And I think in that scenario, it's because, again, that epidural is helping with the nerve pain that's going down your leg. And that's what's causing that pain. And not everyone even knows that. And so education can go a long way when it comes to managing pain and understanding the etiology of it, what the treatment plan's actually going to treat, what it may not treat. It's really important to have these discussions and understand your care so you can be sure that you can advocate for yourself and what you truly are wanting.
Let's say you do the epidural and his leg pain gets better. But the back pain is still so significant that it's really inhibiting his quality of life. Are there other minimally invasive things you can do for the degenerative back part to improve things for him?
Sure. And really, this is an age-based discussion. Now, we already cheated and said Joe was older. Now, if one of you came in my clinic and you said, hey, my back hurts, I'm already thinking a totally different thing than everything we've talked about, because the other end of this is anterior column axial pain. So this is our younger listeners that are usually either a very young 60-year-old who's out doing all kinds of things and busy, or 30s, 40s. I've treated 20-year-olds with this. Where you get, rather than a degenerative, like arthritic process, you get an inflammatory process in your back that causes back pain. And so with that, it's called anterior column axial pain. And these patients are always the easiest to spot. You'll walk in the room to visit with them, and they're standing up. They don't want to sit. And they can't sit still. They're moving around. If they're young and they're having this kind of back pain, you'll look at their shoes, and they'll have the Hey Dude shoes on, the slip-on shoes. I could do a study on this.
The slip-on.
I should be sponsored by Hey Dudes. And so you'll ask them and say, hey, you want to sit down? They'll say, no, my back hurts when I sit down. And so these young patients, that's a different process. And you all probably seen them before.
Oh, yeah. Yeah.
And so these patients, even though they only have back pain, actually do need an MRI. And so it's like the only time you order an MRI for back pain. And you've got to be careful about how you're wording with insurance when you order it. But when you look at them, they will have disc degeneration, like we talked about earlier. And if it's been there for a little while, their vertebral end plates or their vertebrae around the disc will get inflamed. We call this modic end plate change. It's a very old word in radiology, and it's an utter battle to get the radiologist to comment on the report with us sometimes. But the end plates become inflamed, and so it hurts to sit and bend forward. And so it's really miserable, actually. If you watch, it's awful. You can't ride in the car, you can't sit down. You have to either lie down or stand up. And so when they come in with this and we see them, these people actually don't usually get a regular injection. We get the MRI, we look at their findings, and usually I'm probably 75% accurate with guessing this just from a physical exam and walking in the room.
And the Hey Dude.
And the Hey Dudes, the Hey Dude sign. You'll look at this and we do something really interesting called a basovertebral nerve ablation. And so this is not an injection. Are you all familiar with kyphoplasty for a compression fracture?
Yeah.
And so it's a similar approach to that. You take a trocar or a big needle while the patient's asleep all the way with the breathing tube. You make a very small incision, smaller than your pinky thumbnail, and you put that into the vertebrae. And there's this nerve that lives inside the bone, almost like a tooth. So, when you have a root, God forbid, I hope you guys have not had a root canal. It's not fun. When you have a root canal, the dentist drills in your tooth and blends up the nerve and kills it. But they put a cap on it and the tooth is still there. It does everything it did before. You just don't feel it. Your back does the same thing as a tooth with pulpitis. The bone gets inflamed. There's a nerve inside of it that we can go and ablate on the inside of the bone. And that nerve never grows back. It's unmyelinated. It's really neat. It's kind of like a root canal for a tooth. And this is the best procedure because these patients are like your all's age. They come in, they have they're fine. They have one level of disc degeneration, no leg pain. We find this, we do it, and they don't come back. These are not chronic pain patients.
One of those where you feel like, yay.
It's my favorite thing in the world. Like all good things, it's very hard to get approved by insurance sometimes. And those patients are easy to find when you're in your clinic because they are young, they're healthy, and they just can't.
Are there any other procedures that we have missed talking about today that are common for lower back that you do?
Yeah. If you've had back surgery in the past and you show up and your back still hurts and you have scar tissue and you don't need more surgery, we do things like spinal cord stimulators, which everybody is, I don't want that battery in my back. But it's a really neat tool for patients who've had back surgery that don't need more surgery and can help them a lot. I do a lot of them for my patients because we see a lot of difficult, chronically having back pain, fail to respond to injection type patients that come to me for second opinions. But it's a great tool for people that don't get better with the easy stuff and the ones that don't need more surgery. So those are not for patients that herniate another disc above their lumbar fusion. No, that's not for that. Your back and leg might feel better, but your foot won't work anymore, and then you've got to get surgery anyway. But this is for people that have chronic inflammation or scar tissue around a nerve that still hurts after surgery. There are some other less common things we do them for, but I enjoy the spinal cord stimulators for sure. There's something called a mild procedure we do sometimes this is typically more for Medicare patients, but it's a minimally invasive lumbar decompression where we take a small trocar, again, needle while they're asleep, and we clear out some of the flavum. There's a ligament between your spine that can cause compression of the canal. This is for neurogenic claudication or the patients that walk around with a shopping cart and their legs get heavy. I still try to route those patients after if an epidural steroid injection doesn't work to a surgeon, because I think that's still, if you're my mother, you would go see a surgeon if that was your problem,
Yeah,
right?
yes.
And that's what I do for every patient. If you were my family, what will we do? We would do that. If they have too high of risk for a big surgery or they've been told they can't, too many levels with problems, we can sometimes do that as well. It's a neater, less invasive procedure. Yeah, we do all kinds of cool stuff at the pain clinic.
I think hearing all of this, we can take away that back pain is very complicated and can be caused by a lot of different things. And depending on whether it's the front part of your spine, the back part of your spine, whether or not the nerves that go down to your leg are affected, really affects your treatment plan. And so making sure that you see your primary care doctor about it and have a good plan as far as getting the right evaluation and then getting to the right person, whether that be a pain specialist or a spine surgeon. And any tips for patients about, you have seemed so thoughtful in talking today about how you approach a patient. Any tips for people out there on how to find a good pain specialist?
Sure. I think an easy piece of advice is to ask your primary care doctor. You all have relationships with people in town. And usually when we see a patient, if we have a bad interaction or they're not happy, they come back and the first person they tell is you all, right? So if you send 20 patients to a doctor and they all come back not happy, maybe not them. Google is an interesting new tool we don't talk about a lot. And you can get on Google and see whomever it is. I think in general, finding a fellowship trained doctor, I would always ask if you're going to see somebody for this, and it doesn't need to be me, whomever it is, the patient should ask, if I'm going to be recommended for an injection, who's going to do the injection? Because believe it or not, there is sometimes this Houdini trick that happens in some places, everywhere, not just here, where you'll meet somebody, they'll be really nice, and the day of the injection, you're like, who are you?
I heard this complaint multiple times from people. Yeah.
And it's a revolving door of people, and it may be a doctor, it may be a nurse anesthetist, it may be a PA. And really, for me, if I had my mother seeing a person to do an injection, I would want her to see the person for her first visit for a consultation. I would make sure that they listen, because at any visit with a specialist, listening is the most important thing we do. Don't walk in and tell them what's wrong with them. I looked at your MRI, you got a pinched nerve at L5, we're doing this epidural. Hold on, my back hurts worse than my leg. And make sure they listen. And then just make sure they're the person who's going to be doing your injection if you get one. Because I don't like the model of other people just feeding me, being a technician and not actually talking to the patients. Actually, I'm really good at getting behind like I did today. Because I'll do my injection block and I'll have these patients on the table, and I unfortunately can remember everybody's name all the time, so I usually know who they are anyway. But I'm like, hey, how's your back pain? We did this ablation for you 3 months ago. Oh, it's doing great. I'm here for my leg pain. And I'm like, hold on, we're doing an ablation. Why are we doing an ablation? And I'll cancel the procedure. You've got to sit and make sure that what you're doing, even on the injection day, makes, if you're a 10:30 patient and you listen to this podcast and you come in my office, don't pick the 10:30 appointment. You'll probably get your injection at 11:30. I sit and I try to talk, and I try to make sure that everybody feels like they weren't rushed in and out of even an injection too. But I do every one of them myself in my office. And I think that's a really important part of it, is that the doctor sees you for your first visit. The doctor looks at your MRI if you have one, and the doctor is the one doing your injections. You know?
That's great advice.
That is, yeah.
And it's not everywhere.
Because I think, to your point, in this whole process, the history and physical is just as important, if not more important, than the image. And sometimes we don't necessarily realize that. But in this situation, it is. And so you really want someone who knows your whole story doing your procedure.
History and physical is definitely more important. And you can't get a history and physical exam without talking to the patient and listening.
Absolutely.
On that topic, I felt like I had a lot of patients where I would send them to see a pain specialist, and they would see one of the nurse practitioners or physician assistants first, and then they would be set up for an injection with the physician that they hadn't talked to. So what would you tell that patient when they go in and meet, and the person they meet is not the person that would do the injection? What should they do?
I think that it's really important as a patient, and even if you come see me at some point, to self-advocate. And if you get into the procedure room and you're getting an injection from someone you've not met before, it's okay to say, hold on, I'm not laying on that table yet. Let me see your face. What do you think is going on with me? And make sure it aligns. Because if they come in and say, hey, Dr. Milburn, we're doing an epidural for your leg pain. You're like, nope, leg doesn't hurt. Make sure that you understand what you're getting and what you expect. And you can do that with a PA or a nurse. Like, I don't want to make it sound like PAs and nurse practitioners can't do some of this stuff. But if they're not the ones doing the injection, there's a very big potential for a lack of alignment of goal with your treatment plan with what's actually going on. And that could be a doctor too. There are doctors that walk in and they're out in 30 seconds and they write your note and they 99204 you and move on to the next patient. And just my advice for anywhere, me or anywhere else, is make sure that you explain both what's going on and why you are in the chair. Because you can have leg pain, but you're there for your back pain, or vice versa. What's going on? Advocate.
Great. Yeah, that's great to hear.
One last question. Sometimes you're seeing patients, you've done procedures, but then they end up going and having a surgery, and that helps them. But over years, over time, maybe 5-10 years, they have recurrence of symptoms. Does that mean they can't come back to you, or is that something that it's more of a longitudinal relationship that you may see people even after a surgery?
Sure. And actually, I'll tie that in with one more too. So if you get surgery, you're established, you're a patient. I always encourage my patients to either make a follow-up after your acute surgical pain is resolved. Please don't get out of the OR, go home, show up and say, hey, I had back surgery. The doctor said you were going to write my pain medicine for me. That's like acute surgical pain. If you come back and say, hey, I'm a lot better, but I'm still in this nagging leg pain. Can I see you back? Of course. And those patients are really rewarding to treat for me a lot. And I always try to keep tabs on them and see them back. And another thing we didn't really talk about that I try to do all the time too, pain management in Lexington, especially where we are, is not a big world. Like there are lots of people that do similar things to me. And it's not uncommon, as weird as this is going to sound, is that I send patients to my quote unquote competitors routinely. We will pick each other's brains. I talk to them all the time. Just this week, I had the sweetest lady. She had gotten several injections and gotten a small procedure, and she wasn't getting better. And I was just hitting my head against the wall. And so I picked up the phone and I called another doctor that does what I do and said, hey, man, do you mind to help me out and just lay a second set of eyes on this patient? And man, she was so appreciative. She came back. She was about to cry. She said, thank you so much. Because it's a bit of an ego hit. You want to fix everybody all the time and make them better. But the reality is sometimes a fresh set of eyes on somebody can be really helpful. And if someone does that, even I'll say, hey, their opinion, see them. If they take good care of you, you're fine to stay there. You're not required to come back, but please, you're always welcome back. And I think there's this like belief in medicine sometimes that we need to be a one-stop shop to fix everything all the time. And I really try to abide by that rule we talked about earlier, which is if you were my parent on this table or in the chair, what would I do with you? And sometimes that's a second opinion. And if it's initiated by me, it's a lot easier for them to get than for them like going out and doing it on their own. And so I'm not hesitant to do that if I'm not getting where I want to be. They're not like a surgical candidate. Obviously, see a back surgeon if it's a surgical issue. But yeah, I'll see people back anytime.
How can someone come see you?
We have a website where there's a self-referral form. I'll ruin the surprise a bit for you and tell you that if you fill that out, they're going to ask you who your PCP is and then harass people to send us all your notes and everything. So in general, the best way to do that is probably through your PCP. And they're really good about talking with you and just ask them. And if they're interested in seeing me, my name's Shawn Milburn. I'm at Commonwealth Pain and Spine on Richmond Road in Mandawar, the big, large, curved black building there. And I'm happy to see patients. In general, I think that with a self-referral or someone who's not in acute severe pain, I try to see people within 2 to 4 weeks of a referral. If it's more urgent or I get a call from these gals, I'll get you in within a day or two if it's an acute urgent need. I'm happy to see anybody, second opinions, always happy to give you a look and listen and see what I can do to help.
I feel like you've given us a really good perspective on the complexity and options for back pain. So if you guys have any further questions, please click on that link that says send us a text or email us at contact@thestartingatePodcast.com. And next week, we will be talking more about musculoskeletal issues and the role of osteopathic manipulations with Dr. Selena Rains.
See you next week.